करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय ज्योति नमोस्तुते शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय ज्योति नमोस्तुते शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय ज्योति नमोस्तुते
Good evening, everyone. It gives me immense pleasure to welcome all of you to this program by the International Academic Exchange Committee, and the theme of the program is Mixed Bag. We are really privileged to have with us today the chairperson of the committee, of course, Dr. Varsha Baste ma'am, and as well as Dr. Alpesh Gandhi sir, the president of FOXI, and Dr. Archana Baser, the vice president of FOXI, and also the vice president in charge of our committee. International Academic Exchange Committee has been doing excellent work in the last, in this year or so. And I would also definitely want to say over here that we get these opportunities for this program is because of Dr. Alpesh Gandhi sir, the visionary president who has really revolutionized the teaching process of FOXI in this COVID pandemic period. He has really taken up well, and the e-learning process of FOXI through the various platforms has really made it so easy to learn things from the comfort of your home. So today we have with us an excellent program that has been designed. We have two international speakers with her, and of course with us the third speaker, Dr. Jayam Kannan ma'am, who's the ever-loving and always energetic person who is like a teacher of teachers for all of us. So I would first of all like to welcome Dr. Varsha Baste ma'am, who is the chairperson of the International Academic Committee, to kindly welcome all our delegates and also our faculties present here today. Over to you, Varsha ma'am.
Good evening. With warm heart and affection, I welcome you all. As a chairperson to International Academic Exchange Committee of FOXI, I am very, very privileged to have the stalwarts from international and national platform. They are really good. Believe me, they have acknowledged for gracing this this occasion that I am very, very thankful to them, because they have high standard of academics. We have our FOXI President, Dr. Alpesh Gandhi sir, and the guest of honor, VP Guide to International Academic Exchange Committee, Dr. Archana Baser, the beautiful guide to our committee. Friends, International Academic Exchange Committee, when I took over, I didn't know what to do, but slowly we evolved and we got to know so much we could do that this year, up to November, we were booked for all international conferences, workshops in different countries. We had tie-up with the government, Spain and whatnot, but only because of COVID, we couldn't do it, fulfill the dreams, but we could have many webinars with international faculties who came over, and with digital exchange of knowledge, we could get many varieties to discuss in this platform. Now, today we have two international speakers, Dr. Beena and Dr. Manjula. I welcome you, madam. And we have been exposed to so many webinars. Thanks to Alpesh Gandhi sir. He has given freedom to us, and so many webinars. Our brain is all occupied with so much of knowledge and academics. But there are some pockets. So we targeted those pockets, and we had webinars for such pockets which were not exposed or discussed, like this today's perinatal mental health. Friends, pregnancy and the postpartum period of 3 months is very, very vulnerable for any women. And so they undergo depression, anxiety, postpartum psychosis and bipolar disorders, they surface in minor or major and giving almost 20% of prevalence for these vulnerable women. So we have two international faculties who are stalwarts and who have worked too much in this perinatal mental health. They will guide us how to diagnose, how to manage, how to treat, and how to avoid the morbidity to the woman and her offspring. And we have Dr. Archana Basir Madam, who has always guided us for many webinars and many workshops that we have conducted. We have always, Dr. Alpesh Gandhi also have given us free hand to do anything, everything, anywhere, and whatever time you want to do. He is always there to support us. Friends, we have, through International Academic Exchange Committee, we have introduced the international travel scholarships also. And I'm happy to tell you that our East Zone coordinator, the young chap, the dashing, the energetic Dr. Priyankur Roy, he is also the convener of this program today. He has grabbed the scholarship of 1 lakh rupees, and also last year, Dr. Saijus had been conferred with this fellowship of 1 lakh rupees. And next year also, we are planning to have 2 or 3 more fellowships if we could, with the help of pharma companies. So the target of International Academic Exchange Committee is not only to exchange the knowledge, but to exchange the training programs also, which our students, the bright Foxians, young chap, who can go abroad and get the knowledge or the trainings from wherever or whichever university or they apply for or they desire. So that is up to them where to go and get it. International Academic Exchange Committee gives the platform for them, and it is all only through meritorious selection the scholarship is conferred to the candidate. So I welcome you, Dr. Alpesh Gandhi sir, Dr. Archana Basir madam, Dr. Jayam Kannan. She is the star, she is the diamond, she is the Kohinoor of Foxy. I have gone through her CV and my God, how much she has achieved in her lifetime. Really, madam, thank you so much for accepting and gracing this occasion and coming over for this webinar. I welcome Dr. Manjula, Dr. Beena also, and Dr. Punita, who was very, very active, our executive for International Academic Exchange Committee. She has been the brainchild to bring her all these academicians together, and she and Priyankur has taken lead in collecting and communicating, conversing with them, and so this webinar is going to happen. I again welcome all of you from the bottom of my heart. Thank you for coming all, and all the audience also for attending it. Over to you, Dr. Priyankur.
Thank you so much, ma'am. I would definitely say under the guidance of Alpesh sir and Dr. Archana Basir ma'am, this International Academic Exchange Committee has done real wonders, and I would really like to thank Varsha ma'am for giving me the post of the East Zone coordinator of your committee. Thank you so much, ma'am. At the beginning, I definitely need to mention that Dr. Punita Rajesh ma'am really came forward with the faculties, her ideas, and then we materialized it, and then finally we have this program today that we are conducting basically. So thank you, Punita ma'am, as well. And so basically to start off with the program, of course, we have our dynamic visionary president with us, Dr. Alpesh Gandhi sir. So I would request Dr. Alpesh Gandhi sir, who is the president of Foxy. Everyone knows him, but for formality's sake, we are just fulfilling the, I'll just go through his CV. So he has been the chairperson of the Practical Obstetrics Committee, governing council member of ICOG, vice president of the Gestosis India chapter, convener of one of the most successful AICOG conferences in Ahmedabad, and of course, as Varsha ma'am has said, he has never said a no to a learning experience, and he has really showed us the path in this COVID-19 era. I welcome you, sir, to this platform and request you to kindly say a few words, sir.
Thank you, Priyankur, for the kind words. A very dynamic Vice President Foxy, Dr. Archana Basir, active committee chairperson International Academic Exchange Committee, Dr. Varsa,
Thank you, sir.
my very close friend, Dr. MC Patel, and very ever-loving, emotional, motherly, caring Dr. Jayam, all the esteemed faculties, my younger brother, Dr. Priyankur, who is more, I can say, who is more available at all the webinars than me, more than me. Yeah. Wherever I am going, I met him. Very good evening to all of you. I extend warm welcome on behalf of Foxy, on behalf of International Academic Exchange Committee to all of you. At the beginning, I would like to congratulate Dr. Varsa Baste and her committee, her team for this excellent work. COVID could not stop any of our committee. All the committees are working very actively, and I think they have worked double than the routine usual in the normal time. So I congratulate all of you, your committee, for continuing great academic work in this difficult time of COVID-19 and supporting all the programs, projects of Foxy. Today also, you have selected a very esteemed, eminent faculties, international faculties, and a very good topic. All the topics are very interesting. A basic and beyond in perinatal mental health by Dr. Beena, integrated perinatal mental health pathways, a step in the right direction for vulnerable women by Dr. Manjula, and another important topic, pregnancy in RS negative mother, improving fetal outcome by Dr. Jayam. And we have eminent chairpersons, Dr. MC Patel, Dr. Punitha, and yourself, Dr. Varsa. And as we all know that in this COVID-19 pandemic also, the incidence of mental health problems increases a lot. So this is very relevant topic for the recent problem also, which we all are facing. There are so many factors for this suffering of women from mental health during this COVID-19. I am not going to speak about anything because we have eminent faculties and they are there to cover, to update us for this burning issue and very important issue. Your committee has very important role. It's a very important committee, not only for the exchange of academics, but also for the exchange of Fox's vision, also for the exchange of Fox's good work, also for the exchange of Fox's community connect work with other countries. And because some problems are so common, like violence against women and girls, all the countries are facing. So we can have joint programs with SAFOC countries, so many other countries. So your committee has a very important role. You can work for the Fox's vision, for the exchange of Fox's vision, to take Fox's vision, to take Fox's good work and community connect programs and academic programs, social work to other countries as well. And I'm sure you will do it, and you are also doing it. So once again, I congratulate you and your committee. I wish happy learning to all the delegates, and I am thankful to our speakers, eminent faculties for sparing their valuable time for us to update us in these topics, and I wish all of you happy learning. I wish all of you safety. Thank you very much for the patient hearing. Thank you.
Thank you so much, Dr. Alpesh ji. In spite of your busy schedule, you made it to come and grace this occasion. Thank you so much.
I just came from Bihar Society annual conference where I was awarded an oration and also inaugurated the conference, and then immediately it was over by 7 p.m. sharp, so I could make it to join here.
Thank you, sir. Obliged.
Thank you so much, sir, for your wonderful words, sir, and thank you so much. We truly know, sir, the way you have been going around from webinars to webinars, and this
we both are going. We both are going.
No, sir, it's you, sir.
Yes, Priyanpur is also so active.
But I will really say, sir, this COVID time and this year will be remembered by all forever and ever, because we have sitting at our homes, the way we have gained knowledge and the way we have learned and the way we have conducted programs, visited places particularly, has never been done before. So thank you much, sir, and thank you for coming and joining our program today, sir. Thank you, sir.
Thank you. Thank you.
So moving on now, we have with us our guest of honor. Session, can I have ma'am slide, please? Dr. Archana Baser, ma'am. Again, ma'am is so very busy, but then she has come and joined us, and she is always smiling and always encouraging, and she has a yes for whatever positive thing that we have to tell her and whatever positive thing we offer to her. So she is currently the Vice President of FOXI. She is the Organizing Secretary of the AICOG 2021, which we are all looking forward to. And she is the Imaging Science Committee Chair of SAFOG. So I welcome ma'am to this platform and request her to say a few words, and also request her to say a few words about the International Exchange Committee that she is the in-charge Vice President of. Over to you, ma'am.
Good evening, everyone. Good evening, President Dr. Alpesh Gandhi, Dr. MC Patel, sir, Dr. Jayam, madam, all our faculties, and my most charming and most dynamic International Exchange Committee Chairperson, Dr. Varsha Baste. Varsha wouldn't know that I had a fight with Dr. Alpesh Gandhi to have this committee under me.
Really? Thank you so much.
I wanted my dynamic Varsha with me because I knew you were chairing, and you have done a tremendous job even in the COVID time. And I really appreciate it that you have brought, you have out of box thinking all the time. So really very good topics you have selected for today. It is very much neglected subject, the peripartum and post delivery health, mental health. And we have very esteemed speakers today with us, Dr. Beena and Dr. Manjula and Dr. Jayam Kanan, to enlighten us on this topic. So very well done, Varsha. You keep up doing the good work. Our support is always there with you. And I know that even with the limitation of not going, we are missing going out. Otherwise, with your committee, we would have traveled to different parts of the world. So maybe in future, we get opportunity to again connect, but you are connected to very many people. I think these webinars have given us opportunity to connect to many people, which we would not have done even physically. So all the best and congratulations. Congratulations, Priyankpur, for getting that award of IAC. And thank you, Dr. Punita, for bringing such a good faculty for us. And wish you all the best and congratulations.
Thank you, madam.
Dr. Varsha, please do not go by the words of Dr. Archana. We never fought. She just requested, and as usual, I am always allowing free hand. So
you don't oblige me. Yes.
She requested me, and I immediately told yes. You all vice presidents can mutually decide.
Just to ignite the again Dr. Alpesh.
I'm so obliged by your edification. I will say that I'm a simple person, but thank you for your love and affection and confidence in me, madam and Dr. Alpesh Gandhi.
Thank you, Archana ma'am. I do not know when we will be able to travel internationally again, but I'm very sure we all Foxians are looking forward to the AICOG in Indore, ma'am, because that's the next biggest conference that we will be able to attend and meet most of the Foxians.
Yes, we are preparing for a big number of people at Indore. We know that everybody is longing to meet physically to colleagues and all. So welcome you all to Indore, and we'll come up with the date soon.
Yes, and before that, I would also like to extend my welcome to my city, Siliguri, where we have the ESON Yuva Foxy, and Alpesh sir has promised that he will come personally to the Yuva Foxy. So, of course, it will be a privilege to have you, sir, with us when we are doing it over here.
1 minute, Priyankur. Let me congratulate and welcome Dr. MC Patel, sir. Sir, you are the most humble and most beautiful human being I have come across. You are my mentor, guidance for giving me little advices, the piece of wisdom and knowledge I got from you. Thank you so much for gracing the occasion and coming over to have the chair. It's a simple post of chairperson. You were the VP Foxy, but you said, yes, Varsha, I am coming for you. Thank you so much, Dr. Patel, sir.
Thank you, Varsha. It's my pleasure and your privilege.
Dr. Varsha, he also fought with me for you.
Thank you. It's nice to hear that the fighting was for me. Thank you so much. I am in cloud 9 now.
So moving on with the academics proper, we have almost 400 plus delegates who have already logged in with us, and I think in this storm of webinars that are happening, that's a very good number that we have. That's definitely because of the good faculties that we have with us and the good chairpersons, of course, and of course Alpesh sir and Archana ma'am who are with us today. So moving on with, first of all, I would like to welcome the chairperson of the first talk, Dr. MC Patel sir. She has very rightly been welcomed by Dr. Varsha ma'am again, saying that she is the right person, being the past vice president of Foxy. He has agreed gleefully to come and chair this session over here. He is a consultant obstetrician, gynecologist, and a medical legal counselor, honorary joint secretary, state organization of Obs-Gynae, Gujarat from 2019 to 20, organizing secretary of the AICOG 2017. This is all formality, but I will personally like to definitely say that Dr. MC Patel is a person whom even if you call at 2:30 in the night with a problem, with any medical legal problem, he'll take your phone and he'll give you advice very calmly over 15 to 20 minutes, which has happened personally with me. And I think that is more important, that is required from a doctor who is helping another doctor. He is a medical legal counselor only for the doctors and has never taken a case against the doctors. So just by saying this, I would like to welcome you, sir, to this platform. And I would like to request you to introduce our first speaker, Dr. Beena Rajkumar, ma'am.
Thank you, Dr. Priyankur, for kind words. And congratulations, Dr. Varsha, for taking a very vital issue for discussion. Because perinatal mental health. But I will go a little further, not only perinatal, prenatal, perinatal and postnatal mental health has its equal importance. And rightly said by Dr. Archana, it is rather neglected or less discussed area. Of course, it is very vital issues to be discussed, but it is less discussed still because antenatal mental health, it depends atmosphere of family also. Support from family members to the antenatal patient, not even antenatal period and during perinatal period also, and then postpartum period also. So atmosphere of family, many a times quarreling in the family or domestic violence in family, not necessarily to the patient, but to other persons of the family members. Then also it has its own impact on mental health of pregnant patient, and not only from anxiety and depression, but it may turn to manic depression and postpartum psychosis. And in very small or few groups, it has its own higher intensity, and it may turn into suicidal tendency also postpartum. So it is very vital issue, and we have rightly, Varsha has rightly selected the topic to be discussed. And for this, the eminent speaker is none other than Dr. Beena Rajkumar. So She is consultant psychiatrist and consultant psychologist of medical education, and she works as a psychiatrist on an inpatient ward for women with complex mental health problem, and as a psychotherapist with people who have experienced repeated traumatic life events. She teaches widely on the subject of understanding and working with patients who have experienced complex trauma, and advises and contributes to its advises on national policies relating to women's mental health. So I think she is the very right person to speak about the subject, and that is peripartum mental health. So over to you, Dr. Beena.
Thank you, sir. Thank you so much. I'm going to see if I can share my slides.
A reminder to all our viewers, in case if you have any questions, please put it in the Q&A box so that we can take it after every session gets over.
Yes.
Yes, you can share your slide, ma'am. Please go on.
Are you able to see it?
Yes, we
Are
can,
you able
madam.
to see my slides?
Yes, we can, madam.
Oh, lovely.
Yes, Dr. Beena.
Okay. So thank you so much. It's such a privilege to do this presentation here. I know Punita Rajesh very well. Dr. Punita Rajesh and I are very, very close friends. So thanks, Punita, for the invite. And thanks, Foxy, such eminent people. Thank you so much for the invite. It's a privilege to do this talk today. I am, as Patel sir said, I'm a consultant psychiatrist. I'm also a consultant psychotherapist. I'm originally from Chennai, southern India, and I have very, very strong roots in Trichy. My in-laws are from Trichy, southern India again. And so it's wonderful to be a part of this presentation. I'm going to be speaking about perinatal mental health, which I think is a very, very important topic. So my agenda for this afternoon is to just give an overview of perinatal mental health, to also think about the consequences of undiagnosed and untreated perinatal mental health, and then perhaps to dive into the different conditions of perinatal mental health very briefly, and then to move forward and think about some of the management principles. I feel with today's, with the COVID and us being in the digital environment, I feel the emotional bandwidth and the cognitive bandwidth is just 30 minutes. So I'm hoping to keep this talk as brief as possible. So maternity mortality rate. So in England, we have the National Confidential Enquiry, which is done every few years, and they collect copious amount of data. And this data was the last inquiry was done in 2016. And it showed that actually the reduction, there has been a significant reduction of maternal mortality. So in 1952, 100 out of 100,000 women died because of maternal mortality. And that's been reduced to 9 out of 100,000 in 2016. Yeah, so very significant improvement in maternal mortality rates. However, very sadly, there has been an increase in mental health problems. The incidence of mental health problems continue to increase. And here in England, we have very, very robust systems to assess and pick up and manage perinatal mental health problems. But perinatal mental health problems continue to be undiagnosed and undertreated. So this was the 2016 stats that showed 13 to 19% of women suffer with postnatal depression. I was doing this, preparing for the talk this morning, and I looked at the stats. The 2020 stats showed 20% of women suffer with postnatal depression. So 1 in every 5 women suffers with postnatal depression. And what is the WHO's prediction? WHO has predicted that by 2030, the number one disorder across the globe, it doesn't matter where you work, it doesn't matter who you work with, the number one disorder across the world is going to be depression, clinical depression. So we are, if you're seeing clinical depression in your cohort of patients, over the next 10 years, expect to see more clinical depression. And if we look at the period during pregnancy and 7 days after delivery, during that period, the number of women who die, the maternal mortality that's directly linked to mental health problems or suicide is low. Yeah, it is low. But if you look at the data of those women who die, 25% of them have untreated mental health problems. So that makes us think about the association between untreated mental illness and poor obstetric outcomes. So the confidential inquiry also says that if you look at 6 weeks after delivery to a year after delivery, during this period, 23% of the deaths are directly linked to mental health problems. And out of this, 1 in 7 women die by suicide. See, the suicide that women who are clinically depressed, the attempts, the methods that they use to kill themselves is significantly different from the methods of suicide that postnatal depressed women use. So women typically, when they're depressed, they try to kill themselves by taking an overdose. So because they choose non-violent methods, it's possible to, at some point, intervene and save them if possible. But women who have postnatal depression typically choose violent methods of suicide, like hanging themselves, jumping from heights, trying to burn themselves, self-immolation, very, very common violent methods of trying to kill themselves. So if we look at what is the impact of undiagnosed and untreated mental health on the mother? So what if during the entire perinatal period, you're just focusing on the physical health, you're not picking up the underlying mental health problems and you're not treating the underlying problems? What impact does it have on the mother? The mother tends to have poor nutrition. Her ability to take care for herself is significantly impaired. Her attendance for her prenatal checkups is poor. Her ability to follow advice in the prenatal period and prenatal advice is impaired. And she tends to have depression that goes on, or mental illness that becomes very prolonged. And these emotional problems are linked with increased hyperactivity of the hypothalamus, pituitary, adrenal axis, and sympathetic overactivity. So therefore, that leads to poor obstetric outcomes and more physical health problems. Her ability to bond with her child and her ability to form a secure attachment with her child, and if she has other children in the family or with her partner and the extended family, is significantly impaired. So this also has an impact on there's decreased fetal growth, small for gestation age, increased fetal heart rate. The neonate will have, there's a risk of low APGAR scores, small head circumference, increased cortisol, and decreased serotonin levels in the neonate. Therefore, a decreased chance of thriving, and the ability to, the child will present with crying and poor feeding and poor sleep, and is at an increased risk of neonatal admissions. So impact on child development. This is an area that particularly interests me as a psychotherapist. So if you look at the first year of the attachment, so right from birth to the first year after the delivery, that period of attachment between the infant and the mother is very, very important. So if you think about the child's inner world, the child is born into a world. It doesn't have language. It doesn't know how to communicate. and it has all these physiological needs. It wants to pass urine, it's hungry, it's cold. It has all these physiological requirements, emotional requirements, and it doesn't know how to communicate that. So the child's primary way of experiencing life and experiencing itself and the world is through the mother. The mother acts as the conduit to experience life, to experience the child itself. So when the mother is able to be, is present, when the mother is able to be responsive to the child and say, okay, that my child is crying, I need to change the nappy, I need to feed the child, or and establishes that contact and coochie coos and the kind of things mums do, gives it a hug and says, oh my sweetie, and all that coochie cooing. All that creates a sense of secure attachment. And this secure attachment helps the child to regulate emotions, helps the child to feel secure, safe, and contained. And that secure attachment is the template for later emotional development and neurodevelopment as a child and subsequently as an adult. It has a knock-on effect as an adult. So attachments are very, very huge. Now just think conversely, if the mother is in a state of feeling very, very distressed herself, she's anxious or she's depressed, and she's not able to be present because of her own inner preoccupations, and she's not able to be present, and she's not able to be responsive to the child, what happens? The child feels very, very uncontained and emotionally dysregulated and unsafe. And such children have neurodevelopmental problems, emotional dysregulation, and they are at a risk of developing attention deficit hyperactivity disorder, conduct disorder, emotional problems, and they can also go on. And this sequelae tends to run into adult life. Their confidence, their resilience in managing emotional difficulties and difficulties in life can be significantly impaired. So if we look at the way in which secure attachment regulates emotions, how do we process emotions? So we collect all the stimuli, the sensory stimuli, and it goes to the limbic system, and the thalamus collects it, organizes the information, passes it on to the amygdala. The amygdala is the center of the emotional brain, and the amygdala then passes the stimuli on to the cortices. And the cortices, so if you are upset, and then the information goes on to the cortices helps you think about, okay, what do I do now? I don't want to just say something because I'm angry. What do I do? It helps us to step back, look at the bigger picture. So that is very, very important. That's how we regulate emotions. And fMRI studies, fMRI scans done on children who don't have secure attachments, who have insecure attachments, show that there is a hyperactivity of the amygdala, which is, as I said, the center of the emotional brain. It tends to be overactive, and there's decreased activity in the anterior cingulate cortex, the prefrontal cortex, the insula, those parts of the brain where we have a sense of I am, a sense of self-awareness. And so there is significant, when a child has poor attachments, it affects their ability to regulate emotions and to develop a strong sense of self. So impact on paternal mental health. This is something, again, that we don't think about. 1 in 10 men apparently go on to develop postnatal depression. So men develop depression too, the stress, and the biggest impact, the biggest trigger for postnatal depression among men occurs when the mother has postnatal depression. So having a child is, as we know, such a huge lifestyle change. It's a huge transition in life. And if the mother is not well, that has an impact on the father. And men typically, their depressive symptoms are more externalizing. So instead of going and withdrawing and ruminative, they tend to be more angry, overactive, irritable, and spending less time in the family home. So the bottom line is, if a mental illness is undiagnosed or undertreated in the perinatal period, it has a massive knock-on effect on the mother, the child, the family, and society at large. So moving on to the specific disorders, postnatal depression. To be honest, I don't actually think of this as a disorder because it's so common. 85% of women who are, in the postnatal period suffer with this postnatal blues. It's because of the fluctuating hormones. It's because of the rapid, massive changes in lifestyle that this tends to happen. And it typically occurs between the 4th and 10th day, and it's self-limiting. It normally resolves in 2 to 3 days. Yeah, and typically all the mother needs is reassurance to say, oh, don't worry, this is normal, you're going to get better, and just reassurance, empathy, validation, and practical support for the baby. That's all. Now let's compare and contrast this with postnatal depression. Postnatal depression, this is the 2016 stats. As I said, the incidence has since then increased. So nearly 20% of women, 1 in 5 women, suffer with postnatal depression. Its peak presentation is typically 2 to 4 weeks postpartum and 10 to 14 weeks postpartum. So at the end of the first month, typically, and the end of the 3rd month, typically. And the vulnerability. So what makes someone vulnerable to postnatal depression? If somebody has a history of, postnatal depression, then the risk of them developing postnatal depression in the subsequent pregnancies is high. The Brown and Harris study has shown that the most important predictors of depression in women are these 4 characteristics. This was a 1980s studies, but it's found to be very relevant, and it's found to be valid even now. And it's also found to be valid in postnatal depression. So women who are typically stuck at home, who don't have a job, who don't have economic independence, who belong to the lower socioeconomic group, who have children, say over 3 children under the age of 16, and importantly, who don't have a confidant. The confidant doesn't have to be the most important confidant a woman can have is her partner and her mother. It's found that when women have their mother, the Indian habit of sending the woman to the mother's house in the third trimester, and similarly the mother coming and staying with the young new mother, is all very, very protective, is all very healthy. So a supportive mother is a protective factor, whereas an absent mother or I'm talking about the pregnant lady's mother now, an absent mother or a critical mother is actually a risk factor. So a woman needs to have somebody whom she can open up to at this time. So that not having these characteristics or having the Brown and Harris criteria makes somebody vulnerable to depression. What are the symptoms of depression? We typically have 3 clusters of depression. So we have the core cardinal symptoms, which is low mood, anhedonia, which is not enjoying the things that a woman normally enjoys. So even after the delivery and, as she goes back to a normal life, she's not able to enjoy the things that she used to enjoy. Decreased energy. So these are the 3 cardinal symptoms. If a woman has all the 3, then we are in the territory of severe depression. Cognitive markers. So what happens in a woman's mind? So immense amount of guilt, an immense amount of shame, feeling that she's not good enough are important, important thought processes. So if we think about this, for a woman at this stage in her life, it's a double whammy, because society's expectations are that a woman should be ecstatic, she should be happy, she should be glowing because she's a mother now. And so that is the expectation. And what is she actually feeling? She's feeling stressed. She's feeling, oh my God, she's feeling irritated with her child. She's feeling low. She doesn't feel able to care for her child. She feels quite disconnected from her child. So that discrepancy-based processing between this is how I should be and this is how I'm feeling, that gap creates that sense of feeds into the shame, feeds into the guilt. And she spends a lot of time ruminating, just sitting and thinking about things again and again and again. And she finds, because she's so preoccupied with her inner world and thinking and being very self-critical and feeling that she's a useless mother, her ability to actually bond with the baby is diminished and her concentration is impaired. So those are the cognitive markers. The third are the biological markers. The biological markers are diminished sleep. Even if the baby is sleeping, typically in depression, women have early morning awakening. But in postnatal depression, they find it difficult to fall asleep because they're constantly thinking about things, and they have diminished appetite, and the diurnal variation in mood. So some parts of the day are worse than the other. And typically in depression, the morning is the worst time, but in postnatal depression, it's the evening that's the worst time for a woman. Yeah. This is a very, very important thing that there is a cultural difference in the way in which women present with postnatal depression. Typically in countries like India, women don't have a psychologizing attributional style. They have a somatizing attributional style. So what do I mean by that? They typically tend to come with lots of aches, pains, feeling that something is not wrong with them, having lots of biological markers, constantly presenting to the doctor even when there's no clear explained physical cause for the frequent presentations. That is their way of expressing distress because of deep subconscious sense of shame and guilt. About women in countries like India typically have somatizing attributional style. So management of postnatal depression. I think the first thing is to pick it up, to have to look for it, to pick it up, and then to hang it in the box of, and put it in the box of depression. What do I mean by that? Because the woman is just so preoccupied with feeling it's all her. It's my fault. Something is wrong with me. I'm a bad mother. So explaining to that woman that this is not you. This is depression. This is what depression does to people. It makes them have these thoughts that they are not good, that they're not good mothers, and that they don't deserve to care for their children. They feel irritable, they feel angry. So this is not you, this is depression. So that psychoeducation and fostering that sense of empathy, validation, compassion is important. Studies have shown that the most important factor that can be offered is validation. Validation Lahi has said that it's the most important therapeutic tool that we can use as doctors to reduce somebody's distress. And then I'm not going to be talking a lot about medications during my talk. I'm just going to talk about 2 medications during this entire talk. And one is for an antidepressant. It is sertraline. So this is recommended by NICE. So the National Institute of Clinical Excellence here has recommended sertraline as a first line for women who have postnatal depression. It has a relatively favorable, its side effect profile is relatively less harmful on the mother and the baby, and its concentration on the breast milk is relatively small, it's marginal. And if you were in an outpatient clinic and you didn't have a multidisciplinary team and you wanted to you diagnose postnatal depression, you might want to start them on sertraline. And the sertraline, the doses, you want to stick to the smaller dose, so 50 milligrams or 100 milligrams, and gradually increase it to 100 milligrams. And the prognosis for postnatal depression is very good. If diagnosed and treated early, it has a good outcome. The prognosis is good. Who are the women who are at high risk for suicide? What are the red flags that we have to pick up? The red flags are typically women who have this huge sense of incompetence as mothers, who feel, oh my God, and that incompetence and guilt and shame combined with hopelessness is a very, very powerful factor for making the woman a high risk of suicide, because she's likely to think, I'm better off, my child is better off if I died, because I'm such a bad mother. Yeah. And she feels quite disconnected from her infant and feels an overwhelming sense of shame and guilt because of that. So those women are at a high risk of suicide. Postpartum psychosis. In psychiatry, we have very few emergencies, and postpartum psychosis is one of them. It's seen in 1 in 600 women. And if a woman already has a diagnosis, has an existing bipolar affective disorder or a psychotic illness, the risk of postpartum psychosis is almost 50%. The typical onset is 72 hours after birth and usually within the 1 week. And this is a psychiatric emergency because it's linked with 5% risk of suicide and 4% risk of infanticide. So if we look at the symptoms of postpartum psychosis, they tend to have a big emotional component. And the emotional component is rapidly changing emotions that feel like a roller coaster. So it's a kaleidoscope of emotions. So the woman feels frightened, feels agitated, feels confused, perplexed in rapid succession. So her mood swings are very extreme. And there are also the other psychotic symptoms. So a few years ago, we had a very, very high profile suicide and infanticide in England, and the Royal College of Psychiatrists and the Royal College of Obs and Gynae came together and put in, and really stepped up their measures in creating awareness of postpartum psychosis after that suicide. So the patient was Dr. Daksha Emson. She was a Indian lady of Indian origin, of Gujarati origin. Her parents were first-generation immigrants who came to England and who had a small shop. And she lived in a big joint family in a small flat in London. And she did medicine, and she fell in love with a white English radiographer whilst doing medicine. And, she got married to him against the family wishes, and the family cut off ties with her for marrying somebody from a different background. And so they didn't, she came from this big, huge joint family, and no one visited her during pregnancy or during childbirth. And after childbirth, she developed a postpartum psychosis. She had this paranoid delusion about her baby, that her baby was inherently evil and something was fundamentally wrong with the baby. And she felt guilty for bringing this evil baby into the world. So she stabbed her baby and she stabbed herself. And so the paranoid delusions about the baby makes the baby at a risk of infanticide. And also there are command hallucination, hearing voices asking the mother to hurt herself or hurt the baby. That needs to be explored because that is linked with both suicide and infanticide. So as I said, this is a life-threatening condition. It requires urgent assessment, treatment, and the woman has to be admitted in hospital. And I said I'm going to speak about just 2 medications during this entire talk because both of them have a relative safe side effect profile. The second medication I'm going to talk about is haloperidol. Haloperidol is a first-generation antipsychotic. It's one of the old antipsychotic medications. But again, its side effect profile on the mother and the infant is quite good, and its concentration in the breast milk is minimal. So pre-existing serious mental illness, if a woman has existing bipolar affective disorder, existing schizophrenia, then we are talking about a high-risk pregnancy and a high-risk, woman having relapses during the postnatal period. The chances is almost 50%. So the pregnancy has to be planned well, and it has to be the psychiatrist and the obstetrician have to work closely together in planning the pregnancy and managing the pregnancy. So for instance, a lot of our psychotropic medications are teratogenic. So you might not want to have the woman on these teratogenic medications, especially those that are high risk for teratogenicity during the first trimester when organogenesis is happening. And you might want to instead try the woman on a different a medication that has a better side effect profile, and then switch them over back to the original medication in the second trimester. So it requires a lot of planning. And the postnatal period, as I said, is especially after the 72 hours, the woman is at a very, very high risk of having relapse. So planning and working very closely. Here we admit the mother to the mother and baby unit, because we're treating not just the mother, but also the baby. And we're treating them as a unit. We are fostering bonding, and we are treating both of them. And yes, and also another important factor is we want to have a psychosocial input, very, very important. So offering counseling for the woman, getting the family involved, ensuring that she has adequate social support are all very key aspects. So prescribing in a woman when she's pregnant and after delivery during the perinatal period is very, very fraught with risks. So there isn't a no risk option at all. There's just a low risk option. So when we think about psychotropic medications, we want to weigh the benefits of, and the risks. The risks of the medication are, as I said, our psychotropic medications have a lot of side effects. Some medications like mood stabilizers, like sodium valproate, carbamazepine, are associated with teratogenicity. Medications like lithium are associated with congenital malformations. Some antidepressants, like tricyclic antidepressants, are associated with obstetric complications, hemorrhage, spontaneous abortion. Some of the newer atypical antipsychotic medications are associated with causing metabolic syndrome in a woman. So she's likely to develop diabetes, develop raised cholesterol, gain weight. And some medications like clozapine pass the breast milk, and they cause neutropenia in the baby. So they are fraught with side effects. So I would say that if somebody has a pre-existing mental illness and they become pregnant, prescribing should ideally done in working with a psychiatrist. And sometimes they do need prescribing, because untreated pregnancy, untreated mental illness that's untreated has a huge impact, as we said, on the mother and on the baby. So that risk has to be addressed too. Absolutely no place for polypharmacy. We want to stick to just one medication and the lowest therapeutic dose for the medication. As I said, if you as the obstetrician wanted to start a medication for depression, please consider sertraline. Sertraline is a specific serotonin inhibitor. Serotonin, the levels of serotonin in women during the postnatal period is low. And so what sertraline does is it brings it to the right balance. Sertraline is, you can start 50 milligrams, and the main side effect is the first 2 weeks, women may actually experience more agitation and restlessness. And then haloperidol is an antipsychotic medication, a first generation antipsychotic medication that's, as I said, if you stick to the lower dose, the side effect profile is quite safe. Okay, so I've spoken about the NICE guidelines management principles. I'm not going to revisit it. So in summary, what I'm going to say is there's no health without mental health in pregnancy. And I feel that the consequences of undiagnosed and untreated mental health problems on the mother, the baby, the family, and society is devastating. We have to prioritize that. And if we are able to diagnose and treat perinatal mental health problems, then the outcome is good. There's an excellent prognosis. So that's all I want to say. Thank you.
So thank you, Dr. Bina, nicely covering the subject. and very rightly said, if it goes undiagnosed, then it has its own impact, not only on patient itself, herself, but on baby, on family, and society as a whole. Rightly said. So, early pickup of the symptom, diagnosis, and early treatment, consultation with psychiatrist, psychotherapist. But of course, family members' support is very much important towards patient antenatally, even at the time of delivery also, and postpartum. And rightly, you mentioned the case of that Gujarati lady married with white radiographer. So why the problem was there? Because maternal part relatives didn't visit her when she was antenatal and even after delivery. So it was mental trauma which happened in this type of cases, and it may lead to this type of problem leading from anxiety, depression, mania, psychosis, and in very few cases, but it becomes serious matter leading to suicidal tendency also. So congratulations, Bina, again, taking subject very nicely, and congratulations to Versa also for taking this subject for discussion, which is vital subject and ignored subject rather many times. So thank you, Versa, for involving me to chair the session, very important session. And over to you, Priyankur, for further proceeding.
Thank you. Thank you, Dr. Patel, sir, for chairing the session. And I really like to thank Dr. Beena, ma'am, for such an enlightening talk. And you've just picked out the problems that we face most of the times in our day-to-day practice, exactly telling us what we need to do about them. Ma'am, we have a couple of questions with you in the chat box. So I would like to take the questions now itself. There's one question from Dr. Megha from Gulbarga, and she asks, major constraints for obstetricians to pick up a mental health problem is in a woman is time. Can we have a questionnaire and score system so that it can be used by staff and taken care of in time?
Yes, excellent point. You know, we have the Edinburgh postnatal depression scale, and that's a very, very useful scale. I think if you have to ask screening questions, the important screening question to ask is, are you able to cope? And asking questions about the biological markers, those are very, very important. Yes, but we have lots of screening questionnaires. I never spoke about the screening questionnaires because I don't know how, because all these screening questionnaires have to also be culturally appropriate, you see. So I don't know about the cultural appropriateness, but certainly asking questions about the ability to cope, about biological markers are very, very important. Yeah. And getting collateral history. Yeah.
Thank you, ma'am. We have another question from Megha, and she again asks, what is your opinion about psychological impact of early discharge strategy?
Of early discharge strategy? I think early discharge strategy, I think it's the psychological impact is good. I think that's what we want to do these days because we want to foster a sense of agency in the woman. We want to ensure bonding in the women. The only time when we don't want to do that is when we are concerned about, when there is an existing serious mental illness.
Dr. Beena, can I ask one question? Nowadays, many doctors are prescribing melatonin as a drug as a general drug to elevate the mood, biotin, melatonin combinations as anti-aging and antidepressants. So what is your take for the nutritional supplements or to avoid this depression?
So I think as we know that nutritional supplements, vitamin D deficiency, all the other deficiencies are associated with an increased risk of depression. Melatonin there isn't a very robust evidence base for melatonin as an antidepressant. So I'm quite, I stick to I'm very, very pedantic when it comes to prescribing. I stick to the NICE guidelines. So I don't know, I would have some reluctance about prescribing melatonin.
Okay. Okay. Thank you.
Thank you. Yeah. Thank you, ma'am. Thank you, Dr. Beena. I would request you to kindly stay on with us for some more time as we continue with this webinar, and your inputs will be very valuable for us.
Thank you. Thank you so much.
Yeah. So moving on, now we have the second talk for this session. And to chair this session, I would invite Dr. Punita Rajesh, ma'am. I would frankly say over here that this webinar was totally possible because of Dr. Punita Rajesh, as she came forward and she wanted this webinar, and it's a great platform that we have, because the discussion that we are having is absolutely of day-to-day aspects that we face in our day-to-day practice. So introducing Dr. Punita, first of all, she is definitely a very, very important member of the executive committee, member of the International Academic Exchange Committee. She has held the post of Joint Secretary, Treasurer and Secretary of the Trichy Obstetrics and Gynecological Society, and she has attended many national and international conferences and also presented a number of papers. So welcome you, ma'am, and then I request you to kindly welcome your friend Dr. Manjula for her talk in this platform. Over to you, ma'am.
Thank you, Dr. Priyankur, for those nice words about me. And I thank you once again for coordinating this program. When I asked Dr. Varsha ma'am about the program, she mentioned your name and you did it actually. Thank you so much for bringing my dream so well. And I actually, both Dr. Beena and Dr. Manjula, my friends, they are my batchmates, very meritorious students they were, and they are doing very well. And I'm happy. When I asked Dr. Beena, she said immediately, you tell me the date and time. And the same way, Dr. Manjula, she told me, anything for you. So I am very grateful to both the speakers, and I know they would do justice, I mean, more than that. And I'm very happy that Dr. Beena has thrown light on such an important subject. And now I welcome Dr. Manjula. And I thank Varsha madam for giving me this opportunity, because when I asked her, she said immediately, okay, you coordinate with Dr. Priyankur, and that's how everything had started. And now it's really like very lively. Can I have the slides of Dr. Manjula, or else I should? Yeah. Dr. Manjula Samiraju, she has done her FRC OG and MRC PI, and she is the lead clinician for maternity governance at Peterborough City Hospital Northwest, Anglia NHS Foundation Trust, and she has developed various projects on improving maternity care, which has been recognized and shortlisted for national awards. And she has developed a strong interest in exploring vital role of combined clinical and human factors in improving safety and clinical outcomes, especially in high-risk pregnancy. When she was a speaker in 2018 at our society, when I was the secretary, everybody was like impressed the way she spoke, and she didn't even look at one of her slides, and everybody was amazed. And our Jaimkanan madam, she was the Vice President, South Zone then, and she was inviting her for ASCOG Bengaluru, but Manjula couldn't join us during ASCOG Bengaluru. Now she'll be talking on her, the topic. Over to Dr. Manjula.
Thank you, Punita. Can you all hear me?
Yes, we can.
Okay. Yeah, excellent. Oh, thank you so much. Thank you for inviting me, and thank you, Punita, for this opportunity. I'll just share the screen. Can you all see the screen?
Yes, we can.
Yeah?
Yes.
Yeah.
That's brilliant. Okay. Oh, thank you so much. This is a great opportunity, and I'm delighted to be here with so many eminent doctors. And I think you all agree with me that having a baby is a great excitement for the parents to be, and it's a great joy for them. Not only that, it is a tremendous time for a change in emotional and physical well-being. So what happened in the sense is that I don't think we are giving an equal value for physical illness and mental illness for women as we do for the physical illness. Now, the NHS in England is doing quite a lot in trying to improve the perinatal mental health. Why is that? As Dr. Beena was telling, the main reason or the leading cause of maternal mortality in UK till now is not PE, is not PPH, or it's not preeclampsia, it's suicide. Suicide is the leading cause of maternal mortality in England. So what are they doing for that? So that's the thing in England. They have brought it a 5-year forward view in trying to reform, change, transform the maternity services and the perinatal mental health services so that a lot of women can access early, seek help and try to improve the treatment. So one of the key principles for that is improving the pathways and timely access for them. So they have introduced 5 pathways, and those 5 pathways has been introduced with the help of Royal College of Psychologists, and that has also been standardized by the NICE guidelines, which is our National Institute of Clinical Excellence, which gives us a guidance for all the physicians and the NHS Trust in England, and where we have to try and implement that as much as possible. So I'm going to talk about our experience in terms of how we manage to do these pathways, implement the pathways, what we have achieved by that, and what sort of challenges we are facing with the implementation of this pathworks. So we are in the region of East of England. So can you all see as a slideshow, or is it coming as a just a slides?
We cannot see. You have to move forward. Your slides are not moving.
Right, okay, just a second. I think. Let me try again.
Yes, you can go out and come back again if you want.
Can you see now?
Yeah.
Yes. You can.
Yeah?
Yes.
As a slideshow? Yeah?
Yeah.
Yes.
Okay. So can you see the graph?
Yes.
Yes.
Yeah.
Mandela.
Yeah. Okay.
Yes,
so we are one of the bigger region in a bigger county in the east of England, and there is around 1 million population, and for that we have 3 trusts. The smaller one is at Hinchinbrook, the medium is Peterborough, and the large tertiary center is Cambridge or Addenbrooke's in there. And in Peterborough, we are having quite a collective huge numbers of deliveries ranging between 12 to 14,000 deliveries per annum. And it's been increasing with a lot of immigrants population coming through to our region. So I work in Peterborough City Hospital, which is on the top left-hand side. And you can see the bottom one is our mental health unit. And the one on the right, the aerial view of the Peterborough Hospital, where the whole U-shape is dedicated for women and child unit. And we also have a very famous, world famous cathedral, which is extremely many thousand years old. We also have one of the largest prison in UK, and this is the only prison where they have contain both the male and females. And because it's a big prison and the only one in east of England, we sometimes have up to 600 women per day. And we might have at least 20 to 30 women who are pregnant, ranging from 12 weeks till 40 weeks. And postnatal women where the babies has been taken away and been in foster care. So we are having quite a high, and Peterborough is also a high risk area where we have a lot of vulnerable women and with the domestic violence and sex abuse, which are very high in the area. So what we need to do is that we looked at the pathways. We wanted to improve our care. So out of 5 pathways, the first pathway was establishing a preconceptional care. So what they have said in that is the standard is any women who is pre-existing or when they have gotten a previous history, they should try and see by a specialist mental health team who should analyze and have to make a proper preconceptional care. So what did we do with that? We developed a service. We joined with the Cambridge Hospital and we developed as a Peterborough and Cambridgeshire NHS Trust, and we have got a perinatal mental health. We recruited a big team of people. Thankfully, it has been funded by the government, by the NHS England to all the regions. So we managed to get some money. So as you can see, there's quite a lot of team members being involved in trying to establish the preconceptional care. So any women, so like for example, if a 35 years old woman recently who was in a second pregnancy, who had a severe bipolar disease, and she did develop postnatal psychosis. So we know she's at very high risk of having another episode or another attack, another recurrence. So she has been followed up by the mental health team, and they referred her to the perinatal mental health preconceptional care. What they do is they assess her current mental state.
Sorry, Dr. Manjula, your slides are not moving.
Oh, is it? Now?
No, not moving. It's the map there for a long time.
Oh, is it? Sorry about that. I'm sorry. It looks, I don't know what's happening in this.
You can, yeah.
You can relog otherwise.
Okay. What are you seeing now?
Preconceptional care slide.
Yeah, preconception. Yeah, that's the one. Okay. So this is the one that we've been doing this, and it seems to be working. Can you see the second slide?
Yes.
Pathway 2? Yes. Okay. So the pathway 2 is about a specialist assessment. So if the women get pregnant, or women in early pregnancy, or if you've been diagnosed with mental health issues, is how she has been managed and how we can refer her to the specialist. So this is the second pathway. So any women who needs to be seen by the specialist center, once the specialist center receives the referral, then the pathway starts. And we have a very restricted time that they have to see them within certain time limit. So they see them, they assess, they do a biopsychosocial assessment, they develop a care plan, and they involve the entire integrated team. It's the secondary hospital, midwife, GP, and we will come up in terms of what would be the best plan of care for them. For an example, say, for example, we have a 42 years old who had a previous 3 children in a different places. So she has come for a booking visit. So we have a My Pregnancy Notes, which is an online one where as soon as any women get pregnant, they notify us. So they notify the hospital, or the GP notify the hospital through this. Then we have a team of community midwives. So the one on the picture is all the midwives from our hospital. They are the community team. So what they do Wooley's questionnaire. So there is a questionnaire they use it during the antenatal period called Wooley questionnaire to assess or to see is there any risk for them to develop a mental health or whether it's a pre-existing condition. Then what do? If they have got a concern or if they think they might have some mental health issues, they refer to the specialist midwife. So in our trust, we have 2 specialist midwives, one for severe or serious mental health illness, and another person is for vulnerable women. So what they do, they jointly work together, they assess and they see, okay, whether this patient or this woman can be monitored by them, whether they need any specialist input, whether they need to be seen in the antenatal clinic by the obstetricians, or whether they need a specialist care or a joint care. So the specialist midwife look into it and they streamline the process. So this is the second pathway. The third pathway, I think this is the slide that I'm going to spend some time, because this is where we all struggle. Suddenly when we come across with the women who show severe mental health issues, who are having a crisis. So this is the time where it's always a bit tricky in terms of what to do when you don't have enough of team around, when you don't have enough of people around. Suddenly you come across a person. Well, it's nicely saying the pathways and in the government policies that if a woman needed emergency mental health care, immediately we have to refer to the appropriate team. So the pathway starts once they get the referral, and they do the assessment, they treat them, and they admit and they plan the medication. It's easy on the policy, but in reality, was it an easy one? Well, I can give an experience where I was on call. I've been called to see a lady who was 40 years old, prime. She developed preeclampsia and she was admitted in the hospital to control for her blood pressure. She was on medication, and the midwife noted that she was talking to her own and she was sometimes laughing on her own loudly. And they thought possibly she's talking over the phone to someone and they're having the earplug and talking to someone. But then they realized that she was trying to jump out of the window, and she also threatened people to try and harm them. And she was telling that she wanted to hang herself. So which showed that she started suddenly showing very severe symptoms. So immediately the midwife escalated the on-call team. So we have to go. But the problem is we don't use haloperidol, or we don't have any medication apart from opiates, apart from pethidine and morphine. We didn't have anything at the time. And she became really agitated and she wanted to go home. So what we did is we quickly called the specialist midwife, a mental health midwife, who they have a good training. They have a perinatal mental health training. They tried to speak to her. In the meantime, we called the psychiatric liaison service team. So psychiatric liaison service team is made up of one psychiatrist or one psychologist or one psychiatry nurse. So they are on call for a hospital. They base on emergency department. They provide emergency treatment for acute psychotic episodes in the trust for the first 24 hours. So what they did, they came and they immediately gave her haloperidol. So and they sedated as well. So because she became so aggressive that she was trying to jump out of the window. So then it was really difficult. We didn't know what exactly we can do. And she's 30, at the time she's 32 weeks as well. We couldn't able to check her blood pressure. She didn't allow anyone to come near to her until she was being sedated. Then we have a fast response service, which has been developed by the perinatal mental health team, where they try to see these sort of emergencies. Of course, because it's very, as Beena was telling, that these people are become so violent. They have violent thoughts, and it's very difficult to really manage these people when they show symptoms. And it's very important to try and address much quicker. So they got in time, they came. And the other thing is, like, we got their family. It's very important to speak to all the family members to try and see how they can support, what happens if we have to deliver the baby, what happens if she goes to the mental health unit. So there's quite a lot of a plan of care that we have to make it in a very, very careful and very thoughtful process. So we have to admit her to the mental health unit. We don't have a mother and baby unit in our hospital. In UK, there was only 14 places that they have mother and baby unit. So we couldn't deliver her. We tried to admit her in mental health unit, tried to help her to see whether she can able to calm down, she can able to get better, whether her symptoms are controlled. But she didn't take medication. She was splitting her medications. She didn't take labetalol. Her BP was so difficult to control. So we have to deliver her. But again, we have to do the capacity assessment, and we did a mental act. We did a section earlier, but we have to take the section away and then put it back again, because it was very challenging. When she was completely fine, she went to tribunal court to try and take off her section act, which she did. But then we have to go back again to the lawyer. We have to try and put it back again for mental action. And then the tribunal in the last time the tribunal was with us, they agreed that we can able to go ahead and do the mental act. Then we were able to deliver her, and as soon as we delivered her, within few hours, she became extremely violent. So again, we have to sedate her, and we have to find a bed. So we have to send her 2 hours away from Peterborough to mother and baby unit. But you can see how a lot of people have been involved in trying to address this women. I don't think I would have been able to do it on my own or with the staff who's not been used to see this very, very often. And also we are not used to give them antipsychotic medication. So it was really challenging situation. And the family members are, they were initially supportive, but as soon as we put a section act, they really don't want to move her to a different place. So they were causing a bit of hindrance. So we have to explain, we have to try and speak to the partner, we have to try and address the family issues as well, in terms of trying to see how best we can able to do that. The pathway 4 is mainly the medication. The pathway is mainly what sort of medications we have to do. Now for pathways 4 and the pathways 5, which is the inpatient care, again, this for both part 4 and 5, we need the psychiatrist input. We needed the perinatal mental health input for them. So this both part 4 and 5 is for a specialist center and specialist team to help us with. So basically, we were being more concentrated from our level is level 1, 2, and 3, and 4 and 5 pathways where we rely on our perinatal mental health specialist. Yes, we managed to do that, and I found that it was very helpful to have so many people in there to help that woman. She got discharged after 2 weeks, and she's now 6 months. She's absolutely fine. She doesn't show any symptoms, and in fact, she was telling her GP that she's planning to get pregnant again. However, we did have challenges in terms of setting up these pathways. And then setting up is easy, but maintaining and trying to organize it, it's very difficult. We still have a lot of issues. First of all, is getting the women engaged in the treatment, getting engaged with us, getting engaged to seek help. It's always a big challenge. In England, the problem is if they suspect that the child safety comes really, really important. Everyone have to look into the child safety. So if the mother cannot able to cope up, or if we think the child might be at risk, then child will be removed from the mother and will be under foster care until they find out that they've got suitable family member, or if the mother is better. So women fear of taking the child away. So they don't decline, they won't tell us. So they don't want it to come, and so they go from place to place, trying to avoid. So it's always a big challenge to get the women engaged. And there's a negative attitude as well, especially as Bina was telling, there's a huge cultural issues, especially in Asian community, in Eastern European community, where there's a negative attitudes that bad mom, she's got a mental health issues. So a lot of women, they don't come and seek help. And the funding, the cost is another huge big challenge. And without a cost, is always going to be difficulty in improving the facilities. Even though we have a good pathway setting up, but there's not enough of beds. There's not enough of maternity mother and baby units, and we don't have appropriate staffs. Yes, we wanted to make a change, but we don't have appropriate staffs in being trained in perinatal mental health or able to perinatal psychiatrists. So we need more people in. And in our area, we have got a large geographical one with a lot of rural areas. So it's very difficult to follow up and chase people. As I said earlier, staff training and education has been a very, very difficult one for us. We arrange a perinatal training for all the consultants and doctors. We do a mandatory training session for every year for a whole half a day. But still, it's always a bit very challenging one to get people to come in and get that done. And now the lack of awareness was there before, but now it's getting better. But again, it's especially with the midwives and the GPs. They are the most common people who they come across first to see the patients. And they are the people who have to address and see whether, if the woman has got any issues, then they can able to timely intervene. But not many general practitioners have got that ability. So there's a huge number of general practitioners, and how we can able to educate and train them is always a big challenge for us. And the most important, the other one is the time. You need more time to spend with them. You can't have 5-10 minutes or 15 minutes to do a consultation. You need 1.5 hours to 2 hours or even more, probably a day to spend with one person, which is the biggest challenge, I think, for us as an obstetricians. We can't able to have that sort of thing. I think this is where it's very important to get more people in and a specialized team to try and support them. Language barriers is another one we are currently facing, because a lot of women, they don't speak English. Whether we have a huge Eastern European immigrants, Asians, where the language barrier is another very difficult thing to convey and able to address that. So we are trying to come up and see how we can able to oversee, but we are trying to stick to this 5 pathways, where one is the preconception advice, trying to get as much as people, encouraging, doing a lot of community awareness program, trying to put posters, trying to do Twitters, Facebook, try and see how we can able to encourage these women to go and get some help, go and get some right advice before they get pregnant. Then we get the specialist assessment. We have a perinatal mental health team trying to utilize their one. We're trying to streamline who needed what. So we are educating and training all the obstetricians and midwives in the hospital to address some women, especially when they are having mild depression, mild anxiety. We can able to manage them, and also able to recognize who needed specialist treatment, making sure recognizing that how these women can be able to manage and be develop a plan of care for them. And the emergency assessment, that's one of the things that we are having at least 3 or 4 per year having a psychotic episode or puerperal psychosis. So that's why in our hospital we have annual training, annual treatment. We always have a midwife or a doctor who is trained on perinatal mental health on every day. There's people present around, and with a psychiatric liaison service. Even though we cannot able to keep them every day, even though we wanted to, but annual leave, study leave, there's always something, sometime we don't have anyone. But we try to address that by having 24-hour helpline, or now using Facebook and WhatsApp to try and get the psychiatrist. Then pathway and 4 is basically we rely on the psychiatrist to help us. So in summary, I think we can try and use this as a template to try and address, and this is what we are doing in our hospital, to try and improve the care for those perinatal women. Thank you.
Thank you, Dr. Manjula, for sharing your pathways with us. Like, compared to UK, we in India, we are meeting a few people with perinatal mental health issues. But even then, it's so useful. Like the way you were explaining, it's throwing light, like we need to identify vulnerable people and we need to help them out because we are the care providers. And during this COVID time, a study has shown that it's about 20% here in India. Perinatal depression is about 20% here in India during this COVID crisis. So we need to learn more about identifying these people, as you said, and as Dr. Beena had said, we need.
Oh, we lost her connection, I think, Punita. Okay, Manjula, can I ask you? Your presentation was excellent, elaborative, and it has highlighted what is the condition in UK. But in India, the conditions are really different. Even the gynecologist, the general practitioner, or even the relatives, they will escape the diagnosis unless it is majorly evident, isn't it? And yes, we do not have the infrastructure or systems or SOPs that you have already told us. We do not have those in India. So how to tackle such patients is also very important. So we will take help of only the medications and only the sedatives or mild antidepressants. So the chances of her getting cured or knowing that or diagnosing her condition is also very difficult. And many times we escape, the gynecologist or anybody will escape the minor depression or minor problems. Only the major problems like postpartum psychosis, if she is very violent or something, then only it is evident, and then they start taking the patient to psychiatrist or they get admitted. So what is your take for us to as an advice from your side?
Well, that's a very good question. That's a very good question. I think it's very important in a way that having awareness for ourselves because we come across to see a lot of women, and as Dr. Beena was telling, that the way how they present, they show the symptoms is different to what we see here, and it's very important to address why they're coming to hospital very often. How are they coping with the situation? It's very important to recognize them. I think one is self-education and having some sort of training programs within the hospitals or within the district or within your each nursing home, to try to make sure that everyone who come across to care for these people have got some evidence, some sort of training, some sort of understanding, some sort of awareness of this is very important, because once we know, we identify them, then we can able to signpost them to the right place. We can able to signpost to the right advice. We can able to get the right advice and able to support them and try to prevent them having the postpartum psychosis. And if that's something that having a training package, because here I don't do perinatal mental health clinic along with the perinatal psychiatrist. So as obstetricians, we have the training and we have tasked to see who these patients are. Whoever comes in, we will be looking for, are they at risk? Do they have any symptoms of any sort of postnatal depression? Is there any problem? And then we can able to try and signpost to the right team.
Okay, thank you.
I see Punita ma'am has joined back. Ma'am, if you could...
sorry for the inconvenience. Sorry, I didn't notice that, the power was getting low. Sorry for the inconvenience once again.
It's okay.
Go on, ma'am.
So, I think we can go ahead with the questions.
So, as ma'am, Manjula ma'am, I don't see, as of now, I do not see... No, okay. There's a question from Dr. Sujata Keller, and she asks how to disclose to the patient and her husband or the relatives the doubt of mentally Okay. So the question is, how should we disclose to the patient and her husband or the relatives that there is some mental disturbance that is going on in the patient, and what sort of counseling and treatment that we need to give to the patient?
Okay. So what we do is this: first of all, we have to be very honest. We have to be clearly, we have to address what is the main issue and make sure everyone knows about it. And also it's very important to tell them the prognosis. It's very important that if we treat them early, they can be cured much more. They will have back to a normal life. It's very important because they take, once they've got mental health problem, that's it. They will be putting us in a mad person. So we should make sure that we have to address in a positive note, that we have to address that how important is that they should able to access the treatment and access support. They need a lot of support. So it's very important to approach in a positive way. And I don't know whether we can, in India, whether they provide any counseling service or talking therapies, like we have here as a counseling service and CPT, which is a cognitive behavioral therapy. So I don't know how much it is relevant in India, but that's really good, a talking service. Or relatives, when they talk and support the women, it's very important we have to address in a positive way, telling more about how good the treatment might help the women much better, how she will get back to normal much quicker, and how important it is for her to assess the treatment. So by then you can get the relatives and family to be engaged, rather than telling that in a way that, she's got mental health issue, if we don't treat it then it will be a problem. So it's very important to approach in more positive way.
Yes, means it's like a stigma to tell the patient's relative, and they think that the doctor is wrong, or they take it in any other way. Yeah.
So thank you so much, Dr. Manjula. I think that's all the questions that we have as of now. I request you to stay on in case we get a few more questions. We request you to take it at the end of the session. And I thank Dr. Punita also for chairing the session, and Dr. Varsha ma'am for the inputs. Thank you. Now going on, we come to the last talk of this session, wonderful session. And of course, as Dr. Alpesh Gandhi sir, Dr. Varsha ma'am all have very fondly talked about the speaker, Dr. Jayam Kannan ma'am. So to introduce her, I would like to request the chairperson for the last session, that is Dr. Varsha Baste ma'am. Again, we are all very fond of you, ma'am. Of course, wonderful chairperson of this International Academic Exchange Committee. She is the director of the Pushpa Fertility Center, Nasik, and she is the winner of the prestigious Dr. Anandibhai Joshi Award, and she has been the past president of the OBGYN Society of Nasik. I welcome you, ma'am, to chair this session, and to give a talk will be Dr. Jayam Kannan, ma'am.
Thank you, Dr. Priyanku, for this nice introduction of mine. May I have the slide of Dr. Jayam Kannan, madam? So, Dr. Jayam Kannan, madam, she is the coiner of Foxy, because I must read it, everything, madam. Don't stop me reading it, because everybody, every Foxian should know what a woman can achieve in her lifetime. She was the president of Free Legal and she is the president of Free Legal and Center for Women Trichy since 1992. Friends, she is the member of CHWHO since 2008. She is a course director of certificate course in reproductive medicines in Foxy since 2012. Her major achievements: President of India Medal for Outstanding Performance in MBBS, winner of 13 medals and prizes in MBBS. She has been honored with states first in MBBS, university first in MD, Best Paper Award 4 times, Best Book in Medicine Award 2 times from the government of Tamil Nadu, Durusha Dr. S.N. Pandit Award, Foxy Committee Work, Foxy Community Work Best Committee Chairperson, the Lifetime Achievement Award by IMA, Tamil Nadu, MGR Medical University, Trichy Women Association, Tirumular Society of Siddhars, Academy of Clinical Embryologists, Best Society President Award by Foxy 2030. Publication RCOG Award, Books in Medicine in Regional Languages, 5 and English in 1. And I would like to tell you, she has written many books. She is very spiritual, many books on the temples in our area. And the Distinguished Service Medal by RCOG in 2018, the first Indian to receive this award from RCOG. So, with this brief introduction, may I present you Dr. Kanan Madam, and who is going to speak on pregnancy in RH negative mother, improving fetal outcome. Dr. Kanan Madam,
thank
the
you.
digital platform is for you only. Thank you.
Yeah. Humbly accept all your words. Probably these words are more important for the beginners who have to take up very strong hold coming from the lowest socio-economic strata of our country. Can I be allowed to share my screen, Sheshan?
Yes,
madam.
Yeah.
I would also like to happily announce over here one more thing. Usually, most of the webinars we see that the number that we start with starts decreasing slowly. But definitely, when the faculty is great, as great as the faculty we had today, currently we have 653 participants with us. I think that is really honoring the faculty over here today with us. So, Jaya ma'am, over to you.
Thank you. Now, going to the subject. The blood group systems are nearly 35 in number. It has got the ABO, RH, KEL, DUTF, this, that and all. Public antigens and private antigens are also included, but most of them are found to be associated with hemolytic disease. However, 98% of the testings are done only for ABO and RH incompatibility. What is this RH factor? It was one which was detected in 1937 by Carl Steiner and Alexander when they did experiments with rabbits with RH monkeys' red blood cells, produced an antigen that is also found to be present in the humans. That is how the RH antigen came. We know well we have the dominant D and recessive D, CCEE. A person who is RH negative has two negative straits. A person who is positive can have one positive trait and one recessive trait also. Also, please note, KEL and DUFI are other varieties which are belonging to this group, and KEL is the most serious type. Coming to we have known about RH, now we go about the immunization. We have the isoimmunization, autoimmunization, and alloimmunization. For people to have a general knowledge, isoimmunization occurs in a pregnant woman because every fetus is a foreign one and it is incompatible to the mother, but however the system accepts and takes it over. And if you have a response against your own cells, it is autoimmunization, that what you see in thyroid, Hashimoto's. And if you have an immune system for foreign antigens after the exposure of a genetically different cells, it is called alloimmunization. This is the next word. The third word which you have to know in RH is what is meant by sensitization, what is meant by creation of IgM antibody and IgG antibody. When we have the feto-maternal hemorrhage, which is a rare possibility, the fetal blood enters the maternal circulation and it starts creating, because the mother is negative, it starts creating antibodies, which are of IgM type, which are very innocuous. And that period is called sensitization. It takes about 3 months for this IgM to develop the immunoglobulin G antibody, which are capable of dashing through the placenta and cross the placental barrier. The IgG antibodies go to attack the fetal cells because they are against the RHD. So they destroy the fetal blood cells and start producing hemolysis, various varieties, right from hemolytic anemia to erythroblastosis fetalis. I hope I have given a small base. Now, what happens after the hemolysis in the baby? You can get with hemolysis, jaundice in the newborn, With the hemolysis, the bilirubin level going up in the baby, entering the blood brain, produce kernicterus. And when the bilirubin goes on to such a level and the cells are so much down and it produces so much of hemodynamic changes, the entire body gets swollen because of the severe organ changes and we get the hydrops fetalis. That is how the extent of the disease is manifest. Whether you are Rh positive man or woman, please note 55% are DD small d. 45% are both D, whether it is Rh positive female or Rh positive male. But with the Rh positive female with the female male, it doesn't produce a problem because there is no need for an antibody creation. So now the mother is Rh negative, the father is dominant, both D. So all the babies get Rh positive child only and the reactions can occur. When a mother gets met with a father who has got a dominant gene and a recessive gene, 50% of the babies will have the Rh positive blood and 50% of the babies will not have. So that is a way that they can escape that. Now, normally the placenta is a very good barrier, will not allow the cells to go into the mother. But occasionally when there is a feto-maternal chance and the blood enters the mother's system, it produces the antibodies. Once the antibodies are created, the IgG antibodies are the one which can dash out through the placental barrier and create havoc in the fetal blood cell system. So to make it more clear, a negative meets with a positive man and the positive man produces a positive child and that starts giving rise to antibodies in the female and that goes into the mother and it starts giving antibodies and she is ready with the first child goes without a problem. She is ready with the antibodies already and when she meets with another child in the second time, immediately she starts dashing the child with her antibodies. Out comes the fetal problems which are seen in Rh sensitization and immunization. To summarize this as an algorithm, Rh isoimmunization, a negative man with a positive man, and they produce a positive baby, it goes on to the maternal circulation and gets sensitized and if there is no problem, the fetus comes out without any problem. The mother alone gets sensitized. If she has a Rh negative baby, absolutely no problem. The baby goes scot-free and she goes all right. If she comes with the second pregnancy, the mother is already sensitized with the iso antibody, IgG, the fetus goes in for hemolytic disease for the newborn. What are the cells, what are the conditions which can lead to fetal cells entry to the mother? Yes, ectopic pregnancy, whatever way of treatment. Molar pregnancy, blighted ovum, antepartum hemorrhage, external cephalic version, transfusions, placenta previa is a very, very important thing to be noted. Abruptio placenta, abdominal pelvic trauma in the pregnant women, intrauterine death, any invasive obstetric procedures like amniocentesis or chorion villus biopsy, and the patients who did not have any proper care and had problems of small bleeding and postpartum period and all spontaneous abortions can cause fetal cells enter into the maternal circulation. Now, once we know the cause, next is symptoms, signs and investigations. For the mother, there is no symptom at all. For the baby, you have in utero, at birth, immediately after birth and late neonate. In the late neonate, with the less amount of this hemolysis, you get a hypotonic lethargic child. In the early neonate, with the brain being involved with the bilirubin, you get the kernicterus. At birth, with the severe hemolysis and liver being very much involved and too much of bilirubin, you get jaundice at birth. And when it is extremely severe, all the organs are affected, we get the erythroblastosis fetalis or hydrops fetalis baby. Now, having said the symptoms, signs, what are the tests? The test is the one test which everyone has to do is in direct Coombs test at 24 weeks, and that detects antibody. Then we do the direct Coombs test of the cord blood at birth at the same time with group and RH and hematocrit violence and bilirubin, and hand over the child to the NICU team. During pregnancy, you can also have the Doppler amniocentesis and make it as a Lilly graph of the bilirubin level and get into the details, which will come shortly. The additional tests which may be required, which are available, are the cell-free DNA test and the Kleehas test. Kleehas test is earlier, cell-free DNA test is the latest one. The Kleehas test depends on the fact that adult hemoglobin is more eluded through the cell membrane in the presence of acid than is a fetal hemoglobin. Fetal hemoglobin will produce a nice dark red color, whereas a mother cell will be like a shaded cell. But this test is not required if you find any bleeding before 12 weeks of pregnancy. Should I do this Kleehas test in patients who had first trimester bleeding? Absolutely not required as per all the guidelines. Now coming to the Lilly's graph and Queenan graph, you have this graph which notes down the zone 1, zone 2 and zone 3. So when you are in the zone 1, you are quite safe. The baby has very low risk of anemia. When you are in the zone 2, yes, you have a good hemolysis, may be accountable. If you are in zone 3, you are in a dangerously ill list situation and the child can die anytime within about few days to 10 days. Lilly, good. You can always deliver the baby very well after 38 weeks. So low zone means you can comfortably deliver at 38 weeks, do regular ultrasounds and need amniocentesis if required, and all the studies as antenatally required. If you have the mild and high zone, you require amniocentesis and even cardiocentesis to assess the fetal hemoglobin level, platelets, group, and other things. And you may require a fetal transfusion through the umbilical vein. If you are going to give a transfusion, you should be very sure of giving a O negative fresh blood if the hematocrit of the baby is less than 30%. Now, when you do the assessment, we have the ultrasonogram. Everybody thinks ultrasonogram is the marker for everything. Yes, ultrasonogram, we have the eye drops, we have the ascites, we have the umbilical artery. When it comes to the system, we can look at the skin, we can look at the ascites, pleural effusion, hydramnios, hepatosplenomegaly, cardiomegaly, and placental hypertrophy. But kindly note, none of these factors are reliable. Either placental thickness, umbilical vein diameter, or the polyhydramnios, even if you note a very large polyhydramnios. If you visualize small bowel with the liquids inside the bowel, it may show you that you are going in for a fetal hydrops. That is one thing which has to be carefully looked into. The other marks of fetal hydrops are the pleural effusion, ascites, and the scalp edema. One thing which we can do very clearly to assess is the middle cerebral artery, which is widely used in all systems because it is non-invasive, easily available, can be repeated, and the values can be reproducible in good expert hands of fetal medicine experts. Now, having done all these things, you have delivered the baby. How are you going to look at the baby? Yes, look the baby for any total swelling. Look for respiratory problems. Look for circulation. Look for kernicterus level, jaundice, bilirubin level. And if supposing you miss all these things and you have a cakewalk for 7 days, after that the baby has got the loss of motor reflex, poor feeding and decreased activity, please note an RH negative woman, this baby is going in for problems. Now, management, all of us know very well, anti-D gamma globulin, immunoglobulin, fetal blood transfusion, and phototherapy. These things will come to. Anti-D is to be given at 28 weeks. Whenever you deliver these patients, you keep proper donors for the baby's transfusion. Always, the card should be clamped as early as possible after the delivery. Even before you even take out the baby, the nurse should be ready with the clamps, and you should have a very good, efficient NICU care. Now, going to the prophylaxis, We have the Green Top guidelines made in 2011, but they have archived and said, please look for hematologist guideline, British group of hematologists for the use of anti-D globulin. They don't even say about NICE guidelines. They also give us something more about the details. The BCSH guidelines are minimum dose is 250 IU. RH is a disease which can be prevented very nicely with anti-D immunoglobulin given. For anything, you do not require a fetal hemorrhage test if you are doing it in a patient who had some problem before 12 weeks. Anti-D immunoglobulin should be administered as soon as possible for all event like any bleeding within 72 days, 72 hours. If you have forgotten to give 72 hours, at least within 10 days. If you have an event like bleeding between 12 and 20 weeks, a minimum dose of 250 should be given within 72 hours. Fetal hemorrhage test may not be required also. But any event after 20 weeks, like a bleeding or any other procedure that you are going to do, like amniocentesis, a minimum anti-D of 500 units is recommended by BCHS hematologist guidelines and should be given within 72 hours. Here, a fetal hemorrhage test is mandatory. Continuing on the routine anti-D prophylaxis of the BCSH association, tests for this should be done in all anti-D women after 20 weeks for any additional dose as necessary. If you are going to have an RH anti-D woman who does not have been severely sensitized and if her husband is RH positive, a routine anti-D prophylaxis is mandatory. You may give one dose or you may give 2 doses at 28 weeks and 34 weeks. And before giving it at 28 weeks, if you do antibody screening is preferable. And this becomes the second form of screening required in pregnancy. Continuing on to the routine antenatal anti-D gamma globulin, they say prophylaxis, and it should be regarded as a separate anti-D regardless of or in addition to any anti-D which you are given if there is an additional event. If you are doing an external Catholic version at 34 weeks, that is an additional event in which you have to give another dose. If you find there is an intrauterine death where you cannot look at the baby's cord blood, please give additional dose of prophylactic IgG. If you are going to have a C-section in which you are going to have intraoperative cell salvage, that means you are going to purify the mother's cell and give it in case of extreme postpartum hemorrhage, please note that you require as much as 1,500 units of anti-D. So if you are going to give auto cell transfusion, you have to hike the dose of RH anti-D. There, minimum dose of 72, which was stated by RCOG, continues even now. And it should be given whether in all women, whether she has an anti-D immunity, active or passive. NICE guideline also recommends the same thing, and it says that ectopic pregnancy, if you are managed medically, is not barred from getting this medicine because we do not have any evidence to support a medical management of ectopic pregnancy does not give rise to fetal-maternal transfusion. Here, a minimum of 500 units has been advised. Always keep all auditable records in all these cases very, very precisely for any post-medical legal problem. Now, this is a very important question. Antepartum hemorrhage. I now and then have the patient bleeding every week, few drops of blood. But of course, it's a precious baby. I have to take care of the baby. What should I do? You give 500 IU every 6 weeks. Do a 2-weekly fetal-maternal hemorrhage test. If it shows a hike in the fetal cells, add another dose to cover the volume. Additional dose should be calculated as 125 international units for every ml of fetal red cell detected. If you have detected 10 ml of fetal-maternal transfusion, you know 10 into 100, 1,000 units have to be given. Each new sensitizing event should be managed with the appropriate additional dose, regardless of the timing and dose of the prophylaxis which you are given for the previous event. These are all very specific things which you have to go into BCSH. Now, you come to the cell-free DNA test which is being done in the recent settings. It has got a recent one, a test with a report which has shared that they took about 529 samples. They did the cell-free DNA test from the mother, just a peripheral blood sample. And they also took cord blood cell. They did not give anti-D when the baby was predicted to be Rh negative by the cell-free DNA test. The need for anti-D dosage came down by 29%. And 35% of the women were unnecessarily given this, meaning thereby it cuts a big cost of this anti-D gamma globulin. So cfDNA test is coming up in a great way. In India, what is the status of this test? Rathore et al. In 2009 in Indian Journal of Medical Research has brought out a beautiful article, and he has said, and this test is suitable for systemic screening, avoids multiple visits and investigations for the fetal RhD negative positive status and the anti-D prophylaxis. The determination through single exon analysis may prove cost-effective and safe if performed in replicates. And his data says, stresses a need for inclusion of a non-invasive pregnancy test in routine clinical algorithm for all patients of Rh negative pregnancies also who are at risk of this immunization. When you come to the cell-free DNA and all these things do not have any impact on the disease severity. It depends on the zygosity, the amount of fetal billing, and also the ABO incompatibility, which may give a little chance of support. So managing a isoimmunized pregnancy, look for a titer of 1 in 16 to 1 in 32. More than that is dangerous. If positive at titer, do it monthly. If below the critical level, you can deliver it at 10. If the level is more, look for lung maturity, give antenatal corticosteroids, and deliver the baby below 36 weeks itself. Now, practically speaking, at the end, to give you the nutshell, Rh negative woman sensitized in pregnancy with a husband who is Rh positive. Kindly try to do the husband homozygous or heterozygous and get the indirect Coombs test for antibody assessment after 20 weeks. So, give anti-D at 28 and 32 weeks or single dose. Always give any event like bleeding, external cephalic portion, or any other thing, amniocentesis, or any test which you are going to do, which is an invasive procedure, give within 72 hours. If sometimes there are some people who say that they can give 50 microgram if it is 12 weeks. After that, it is 300 mg ROGAM if it is after 12 weeks. This is left to anybody's decision. The dose can be adjusted according to the Clay-Haas test also. The Clay-Haas test which I was talking about is this says, you see the pink cells of the child and the dull cells of the mother, which is very clearly exhibited here, and it is very easy to measure this properly. Rh negative prophylaxis. If supposing you have had a failure in Rh sensitized women, still the baby was showing some problem because you did not give proper dose. You did not give it the proper time. And the laboratory tests were not properly done. And probably the drug that you gave as immunoglobulin was not the proper comfortable company which you have used. Please note all these things are the factors for which doctors are responsible. The spectrum of the disease, if you have the mild disease, you can deliver normally and put the baby on phototherapy. If you have a little anemic baby, go in for exchange transfusion at a good postnatal clinical care. If you have the child expected to have a problem, delivery at 34 weeks below and go for prior care. If you have a stillbirth, it means that you have gone in for a failure and it is the severest form of Rh negativity. Types of phototherapy, you can have a single surface unit as it is here. You can have double surface unit both up and down. And you have a triple surface unit like this, where this is given like this. You should really see a child in this sort of units to feel how the baby should be suffering, especially after phototherapy. So much of skin changes I have practically seen in many cases. I myself have seen it in my own grandchild, and it was a painful affair for me. When you have a hydrops fetalis, don't think in Rh negative women that is alone the factor. Even though it is the fact to be until proved otherwise, kindly have in the back of your mind that you may be dealing with a cystic hydramnion, or you may be dealing with any heart anomalies of the baby also. Please look into those extra factors in these cases of Rh negative women going in with an Rh positive husband producing a child with hydrops fetalis. You have Rh negative, a diabetic female, PIH female, anemic, antepartum hemorrhage. I put all these things to specific complications to be treated and give routine prophylaxis to the anti-D. In APH, you have to put your full force into action as guided by the anti-D prophylaxis. For this, I request you to see the Appendix 2 of the NICE guidelines and also Appendix 3 of the NICE guidelines for if you are going to take up cell-free DNA test, and that test is to be done between 15 to 16 weeks at the earliest in pregnancy. I really thank you very much for this opportunity, and you all have made me feel like a queen on my big day of this International Academic Exchange. Thank to Varsha Baste for this opportunity, and I hope I have delivered my points to the satisfaction of everybody. Thank you very much. Over to...
What a talk, Madam Dr. Jayan Kannan. Thank you so much for gracing this platform and highlighting everything about Rh isoimmunization.
Thank you.
To summarize, I will summarize it briefly. The test you told us about indirect CUM, it should be done at 24 weeks. Direct anti-G antibody important. MCA Doppler amniocentesis is also important. And that KB test, adult HB, it will tell us red, and fetal HB, which will be dark red. The zone 1, 2, 3 to tell us about the sequelae. So low zone, antenatal follow-up. Mid zone, synthesis, fetal transfusion, O negative, fresh blood, HB should be less than 30%. You should be guarded. Assessment of fetal anemia, very, very important. Fetal hydrops, diagnosis on sonography, also with MCA Doppler. The follow-up of a newborn is also important after birth. So how do we manage? The anti-D at 28 weeks and after birth. Arrange donor, quick cord clamping, very important. And prophylaxis, anti-D immunoglobulin minimum dose 250 international units and within 72 hours or in 10 days. If it is missed, then there are 12 to 20 weeks bleed. If the patient bleeds in 12 to 20 weeks, anti-D 250 IU. After 20 weeks, 500 IU, you can increase the dose according to the bleed. 28 weeks and 34 weeks, anti-D to be given as prophylaxis. If she undergoes LSCS, you can give up to 1500 IU of anti-D, and ectopic pregnancy up to 500 international units of anti-D. And auditable record is very important of giving this anti-D. APH 500 international units every 6 weeks is very important to avoid hydrops fetalis and additional dose to titrate. Cell-free DNA test reduced use of anti-D very, very drastically. And it is a great screening test. Always give anti-D for any invasive procedure. And type of phototherapy also you told us. And what is important, NICE guidelines will give you, to be followed as a guide. Thank you so much, madam, for such elaborate and practical overview of Rh immunization management for the newborn and better outcome of the fetus. Thank you. Thank you.
More than my talk, I think your summary is excellent. You have gone through every point of my what I have looked into. We have been talking about 250 units, 500 units, all these things, gram, all these things, 50, 100, all those things. When I dashed into this routine anti-D gamma globulin prophylaxis, it has got about 15 points, which is so clear. The appendix 2 and 3 are very exciting for us to avoid any medical legal problem. The child at 3 years, 4 years of age, after a mild kernicterus, can go in for problem of the infant. They can come and sue us. In which case, these tests and this appendix which we fill up are going to really keep us away from medical legal problems.
Yes, very important. Thank you.
Thank you.
Thank you so much, Jayam ma'am and Varsha ma'am. Jayam ma'am, a wonderful talk, and Varsha ma'am, excellent concluding remarks. It was very, very nice. Now we come to the end of this wonderful webinar, and I would like to invite Dr. Punita Rajesh to kindly give her vote of thanks. And before I do that, I would say from my side, I enjoyed this webinar totally, and the more reason I enjoyed it was basically because this is probably one of the only webinars in which we finished before time. The time is till 9:30 and we finished the webinar at 9:20. So usually or something late, we managed to finish thanks to our faculties. Punita ma'am, I request you to kindly go ahead with the vote of thanks.
Respected President Foxy, Dr. Alpesh Gandhi sir, thank you so much for being our chief guest for today's program, and Dr. Archana Basu ma'am for being our guest of honor, and all the speakers, wonderful speakers, Dr. Beena Rajkumar and Dr. Manjula and Dr. Jayan Kannan. And a few words about Dr. Jayan Kannan. She is our inspiration, as you all said, and I need not say because she is from our society, and she has been constantly encouraging the juniors, and that's how I'm here. And she's the one who encouraged me, and she's the one who introduced me to Dr. Varsha, and that's how I'm one among the executive committee members of this committee. And
I'm so happy you are with us as an executive member, Dr. Punita, because she rightly sent you to our committee to enhance the, in a broader spectrum. You have been so actively involved in this committee. Thank you, Jayan Kannan madam. You are so generous, so affectionate and lion-hearted lady. Thank you.
It's a blessing to be a part of this committee, and I take this opportunity to thank Dr. Jayan Kannan madam for giving me this opportunity, and I'm looking forward to do more programs for the committee, Varsha ma'am, and thank you. And I thank the chairpersons of the webinar, and I thank the sponsor Bharat Serums for sponsoring this wonderful webinar. Thank you one and all once again. Thanks for the opportunity.
Thank you, dear all. Thank you, the audience, and thank you, the chairpersons. Everybody, I thank you all from the bottom of my heart for getting involved and staying with us and have that academic feast. Actually, all the faculties were great stalwarts, and they poured in their knowledge very well, and we are here to, we will have to take time to take it, to assimilate it all. Thank you so much.
A big thanks to Dr. Priyankur.
Yes, yes, definitely. He's an asset to us.
Yeah, he's from our college. I take the opportunity to inform everyone that 4 of us are from the same college. I'm very proud of our college.
Thank you.
Yeah, so the today's webinar was a prominence of South. Thank you.
I'd like to thank Dr. Beena, who is still here with us. Thank you so much, ma'am. Dr. Manjula, who is there with us, and Dr. Patel, sir, who even after chairing the session, he stayed on with us. I could see he was doing some work listening to us, but then he was there with us throughout the session. So thank you so much, all of you, for being there. And it was wonderful, and we hope that we'll have you Dr. Beena and Dr. Manjula ma'am with us in the future webinars as well. And once we start traveling, of course, we would request you to be with us physically in one of the meetings that we conduct.
Thank you so much.
Thank you.
Thank you, everyone. Thank you. It was a great pleasure. Thank you.
It was a pleasure. Thank you so much.
And of course, Sana and Session from and also Bharat Serum and Science Integra, of course, and Bharat Serum for giving us the platform and organizing it so well without any loopholes, basically, I would say. So thank you so much. Thank you so much, everyone.
And lastly, thank you all the delegates, audience, for your patient hearing and staying. Everybody listen it very carefully and enthusiastically. Thank you. There are many comments I am getting. Thank you.
Yeah, there are many comments. Jaya ma'am, though we are done with the vote of thanks, there is one question I request you if you could take it so that the thing will be complete. It's a question from Dr. Nalini from Chennai, and she asks, following antenatal prophylaxis, whether we need to repeat postnatal anti-D if baby...
Yes, that is what NICE guidelines tells us, that we have to give the dose after delivery, because whatever we have given as prophylactic does not carry on to the fetal-maternal hemorrhage, which is a possibility at the time of delivery. If you have a CFF and DNA test and get it done, okay. Otherwise, we have to give the second dose after delivery.
Thank you, madam.
So,
shortly, International Academic Exchange Committee is also coming up with a conference of 3 days, full international faculties, academic feast and bonanza will be thrown to you all as national and international platform. So we will soon come up with a conference of 3 days with high standard academics. Thank you.
Thank you.
So MC will say Bharat Mata ki Jai.